hemorrhagic shock is going to be a rather common mechanism of shock that you'll encounter in the pre-hospital setting. So with this, hypovolemic shock is just where you don't have a sufficient volume of blood to maintain perfusion within your vascular system. Now, we know blood's transport medium for oxygen, nutrients, chemical messengers, drugs, waste products, all that fun stuff. And hypovolemia is going to be an absolute decrease in vascular volume no matter what the cause. Okay, and it's, like I said, it's a common cause that we run into in the pre-hospital setting. Now, you can have hypovolemia that can be from a medical problem or it can be from trauma, and you'll encounter both of them in the field. When we have significant blood loss, it's going to result in overall volume loss and loss of oxygen carrying capabilities. So this is a kind of a double whammy to the body itself. So when we lose blood, it's going to be called hemorrhagic shock, and when it's just volume, it's going to be hypovolemic shock, or non-hemorrhagic hypovolemic shock. Now, hypovolemia is going to occur whenever you lose bodily fluids. Could be from excessive vomiting, excessive diarrhea, inadequate fluid intake, very extensive burns, or anything else where it would cause you to lose that fluid into the interstitial space, which would be called a relative hypovolemia, because it's not where it needs to be. Now, for your hemorrhagic shock, this is where you're actually losing the blood, and whether it's out of the body or just into a different area of the body, if it's not in the vascular system, it's not doing what it's supposed to do. Right? And so your progression of hemorrhagic shock is going to present very similarly to the overall response of shock in general. So as your blood volume decreases, cardiac preload decreases, resulting in decreased cardiac output. Decreased cardiac output translates to a decrease in blood pressure. When this decrease in blood pressure is detected by your baroreceptors in the carotid arteries, then your sympathetic nervous system is going to get in the game, and the renin-angiotensin system is going to be activated. And so when your sympathetic system is activated, your epi and norepi are secreted, and then your alpha-1, beta-1, beta-2 receptors are going to respond to your epinephrine. This is going to give you that fight or flight. And then your norepinephrine is going to give you a little bit more alpha-1 stimulation with some vasoconstriction and a little bit of beta-1 stimulation. So it's going to make your blood vessels constrict, heart rate and force contractions go up to maintain that blood pressure. The respiratory rate goes up a little bit to maintain the oxygenation. Now, as far as the renin-angiotensin system, it's a little bit less immediate. It's going to help basically keep extra fluid in and increase that blood pressure. But it takes a little bit longer, so it's not going to be seen immediately. So what we're looking at as far as the cycle of hemorrhagic shock, we have some kind of trauma or medical problem, and we have a loss of blood volume from the vascular space. Decreased cardiac output, decreased pressure in the aorta, carotid, and peripheral arteries. This leads to a decrease in delivery of oxygen and glucose and removal of carbon dioxide. And then these baroreceptors trigger the hormone release and the sympathetic nervous system gets activated. Heart rate goes up, contractility goes up, vessels constrict, respiratory rate increases, and urinary output decreases, trying to retain some volume. Alright, patient's going to show tachycardia because of that increased heart rate. They're going to show weak peripheral pulses, eventually progressing to chypnea, pale, cool, clammy skin, all that fun stuff. Then, if we have continued volume loss, it's going to be more than our compensatory mechanisms can tolerate, and then everything gets worse. The brain eventually will become ischemic, the medulla fails, and then we have a severe drop in your perfusion, your blood pressure. Patient's now unresponsive. The heart rate goes up, 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 and then bottoms out. Your blood pressure is going to bottom out. Respirations are going to become inadequate, which leads to a further decrease in blood volume, perfusion, and blood pressure, which leads to tissue death, organ failure, and patient death. So, just a few bad things there. So with our hemorrhagic shock, we have 4 classifications of this hemorrhage, and it's based on the amount of blood loss. So our class 1 hemorrhage, this is a blood volume, now this is on an average 70 kilogram adult, up to 15%, which is about 750 milliliters. Usually this is well tolerated and can lead to mild tachycardia, but is people can handle it for the most part. Class 2 is going to be from between 15 and 30% of your blood volume, which is approximately 750 to 1500 milliliters. Now this can produce your moderate tachycardia, can give you some pale skin and maybe a little bit of delayed capillary refill, but depending on the time over which this is lost, can still be tolerated. Now Class 3 30 to 40% of your blood volume, and now we're looking at 1,500 to 2,000 milliliters. So we're going to have pronounced tachycardia. We're going to have starting to have a failure of the compensatory mechanisms, and we're going to start showing some hypotension. So this is no longer tolerated. And then class 4 hemorrhage, 40 to 50% of your blood volume, or 2,000 to 2,500 milliliters. And this is profound hypotension, in-organ failure, bradycardia, death. So this is a pretty substantial amount of blood at this point. Now your presentation of your hemorrhagic or hypovolemic shock, it's going to be what we consider kind of the classic shock presentation. Diaphoretic, pale, cool, clammy skin, weak, thready peripheral pulses, anxiety in the earlier stages, and then maybe some ultramental status in the later. And that blood pressure is going to remain pretty normal as long as there's not a significant fluid loss ongoing. But if it is, then it can actually start to go down with that blood pressure. Some other early signs might be thirst, where I said tachycardia and tachypnea, but you'll have those mental status changes as well as it progresses on. Now, when we are looking at your hemorrhagic shock, before we talk about managing the bleeding, it's important to understand hemostasis. So the body, like I said before, it's really amazing at how well it does its job and how well it tries to do its job. Sometimes we just get in the way of it. But it has this process for stopping bleeding. It's called hemostasis. And there's 3 phases in hemostasis. So the vascular phase, the smooth muscle coat of that vessel is going to constrict, which is narrowing the lumen of the vessel. And that's going to help reduce blood flow through it. In the next phase, the platelets are going to be activated by exposure to tissue collagen from the injured vessel. Okay, so that's going to be attracted to that injured area and adhere together to form a platelet plug. That's going to help start slowing the bleeding down. And then finally, during the coagulation cascade, this is going to have adequate numbers of circulating clotting factors that are going to transform this platelet plug into a stable fibrin clot. And then hopefully that has controlled the bleeding. Now, there are some times in which these hemostatic mechanisms are going to be overwhelmed by the magnitude of the injuries, or they might be impaired by drugs or dietary supplements or things like that. Illnesses can all affect it as well. In addition, if it's on your arterial system side, it's a lot higher pressure, so that can also kind of hinder the formation of those platelet plugs and clotting. Also, if the vessels are torn or crushed as opposed to just cut cleanly across, they also may lose some of their ability to constrict effectively. Now, when you have a patient with significant bleeding, priorities are going to be airway, breathing, circulation, and transporting to the best available source of definitive care. So for a patient who's bleeding, we want to immediately take interventions to improve circulation, which is going to mean stopping any further loss of red blood cells, because without those we can't carry oxygen. Now, internal bleeding requires surgical interventions. We can't stop internal bleeding. Now, a lot of your other patients, any external bleeding, a lot of times we can actually control it, and the vast majority of times it can be controlled with direct pressure. Occasionally, though, it may not be able to be controlled with direct pressure, or maybe that if you have a bunch of critically ill patients, they may require bleeding control, such as tourniquet or something like that, where we cannot sit there and hold direct pressure. We never, ever, ever want to neglect any external source of bleeding. Okay? So let's say you have a trauma patient who has a lot of different injuries. A laceration of the arm may only be a small portion of that total bleeding that's going on for them. The bleeding from that laceration may not be enough in and of itself to cause shock, but when you combine the bleeding from this with the bleeding from an injured liver or spleen or long bone fracture, that small amount of blood contributes to that total loss and may push them over from, say, a class 2 to class 3 or class 3 to class 4. So you want to make sure that you stop this bleeding, and in every bit of blood that you stop from leaving, you're keeping that blood in the body. Now, direct pressure is best applied by using a sterile absorbent dressing over a wound and pressing it firmly with a gloved hand until bleeding is stopped or controlled. And then you're going to secure that dressing in place using a pressure dressing. If that initial dressing becomes saturated with blood, place an additional dressing on top of it and continue this until you are unable to maintain adequate pressure on the wound. Okay, if we remove the dressing, we never want to check and see if it stopped bleeding, because if you do, you may remove any blood clots that have started to form. So if you get to the point where you have a big enough stack on there that you can't maintain adequate pressure on the wound, you're going to remove some of those saturated dressings, but not the ones in direct contact with the wound, because we don't want to disrupt that clot. All right, then we would place fresh dressings and continue to reapply direct pressure. For your topical hemostatic agents, now there's a lot of different ones that have been available for quite a few years, but it's fairly new in the pre-hospital setting. All right, but depending on where you are, your protocols may vary, but typically they're going to be used as an adjunct to direct pressure in the control of severe external bleeding. And a couple of different, probably three main types you'll see are chitosan, zeolite, and kaolin-based products. Your chitosan is a protein that's from shrimp cell. Your chitosan is a protein derived from your shrimp shells that's been used in powder format and incorporated into fiber form. Now, shellfish allergy typically is going to be a contraindication to the use of chitosan, but there are, as far as I know and as far as research has shown, there's no reports of cross-sensitivity in patients with a shellfish allergy. Now, zeolite is a mineral substance that comes from volcanic rock, and what it does is it absorbs the water from the blood, concentrating the elements needed for clotting. Earlier generations of this produced a pretty significant amount of heat on application. Newer ones have been modified and they're not supposed to have this complication. Kaolin is a fine particle clay, and it's used a lot to make actually china, porcelain, things like that. It's used in cosmetics, medication, industrial applications, different things. But when embedded in gauze, it's going to stimulate the body's natural clotting mechanisms. It's supposed to be fairly safe and effective and easy to use. So whatever hemostatic you're using, follow the manufacturer's instructions for this specific agent. If you use them improperly, they are not going to be effective. But typically your steps are going to include wiping away any pools of blood, applying the dressing or other form of agent to the wound, and then continuing direct pressure. For your tourniquets, if nothing else is working, then you need potentially to use a tourniquet. And tourniquet is just a wide band that's applied to constrict both venous and arterial blood flow. All right, it must be placed between the wound and the heart, so you can really only use it on extremities. Typically, you want to apply your tourniquets as close to the bleeding wound as possible to limit the amount of tissue damage that can occur. But at this point, you're looking at life over limb. There's quite a few commercially available tourniquets, and each one should be applied using the manufacturer's instructions. If a commercial tourniquet is not available, an improvised tourniquet using a cloth, such as a triangle bandage with a wine lass, can be effective, but you must understand how to apply it. Your ideal material is going to be wide material, 1 to 4 inches wide, that won't cut into their skins, like rope, twine, wire, and stuff are not appropriate. Folded cloth is good. A belt could work, but not ideal. You'll make sure the material is not too stretchy. Okay. I've heard and it's been suggested that a blood pressure cuff can serve as an improvised tourniquet, and while it certainly can help with a pressure dressing, it does have drawbacks. So you have to make sure there's no leaks in the tubing that will allow the pressure to decrease over time. You must ensure that valve in the cuff is securely closed. You have to make sure that the Velcro is not going to just pop off and allow the cuff to release suddenly. If you must use a blood pressure cuff, I would suggest taping all the way around that cuff to make sure that Velcro closure does not fail, because most blood pressure cuffs are not going to be large enough to use on either large patients or on thighs. Now, the larger the extremity, the greater the pressure you must apply to control that bleeding. So you're going to tighten that tourniquet until the bleeding stops and secure it. Then you want to attach a label if it doesn't already have one, and write tourniquet on there, or T, big T. And then the time that the tourniquet was applied. And we're never going to cover a tourniquet with bandages or clothing. It must be clearly visible, and you want to reassess frequently to make sure it's still controlling that hemorrhage. Typically, tourniquets are going to be left in place up to 2.5 hours with no significant tissue damage. But even in prolonged transport times, life over limb, their life takes precedence over any potential damage to a limb. Now, another thing to keep in mind with this. Tourniquet application can be very painful for a patient who is alert, and so you might want to consider some kind of analgesia if you have the possibility for it and they're not in decompensated shock. If you have to put a tourniquet on a patient, you should transport them to the highest level trauma center available to you at that point in time. Now, once upon a time, extremity elevation and arterial blood pressure or arterial pressure points were also recommended, but studies have shown that neither one of them are very effective in the pre-hospital setting at minimizing blood and really just kind of take up extra time, so they are no longer recommended for any kind of pre-hospital bleeding control. For fluids, one of the things that a lot of people like to do when they get to advanced, they're like, well, let's go and give them fluids. Not every patient needs a lot of fluid. For a patient in shock, our top priorities are going to be airway ventilation, oxygenation, control and bleeding, and preparing for transport. IV access is important, but you need to be sensible with this IV fluids because you can hurt some patients. You can benefit patients, but you can also cause harm. So you need to think critically about this when we're going to give IV fluids to a patient, especially in hemorrhagic shock. The blood must maintain specific concentrations of your plasma and formed elements. Plasma is not water. Okay, it has water. It's a lot of it is water, but it also has electrolytes, proteins, all kinds of other things in there that when blood is lost, those are also lost. And IV fluids cannot replace them, nor can they replace oxygen carrying capabilities. Okay, one of the big ones that are lost, or two of the big ones that are lost, are blood clotting factors and albumin. Okay, when we add IV fluids to this, that blood is diluted, and dilution is going to cause decreased oncotic pressure, which decreases the ability to maintain your intravascular pressure, keep the fluids where it needs to be. All right, when you have decreased intravascular oncotic pressure, that's going to allow the IV fluids to move from the vascular space to the interstitial space, and that's not where we need it. Additionally, whenever blood leaves the body, it's going to take heat with it. So if the patient in shock is already slightly hypothermic and you add IV fluids to it, that's going to cool the body temperature even more, and the body can't maintain its own temperature. Okay, in shock, there's not enough oxygen in the tissues to produce energy, so they can't generate enough heat. Hypothermia is going to impair the body's blood clotting mechanisms even more, which leads to increased bleeding. Alright, so for administration of IV fluids for patients with hemorrhagic shock, it's usually going to be guided by your protocols, but in general, the current practice is to differentiate between patients with hemorrhages ongoing and whose hemorrhage has been controlled. Okay, and only external hemorrhage can be controlled in the pre-hospital setting. Internal hemorrhaging is uncontrollable bleeding. They must go to a surgeon. Patient with ongoing bleeding, IV fluids are administered kind of with the goal of something called permissive hypotension. So you're trying to find that balance point between maintaining perfusion without worsening the situation. If we give too much fluids, we're going to dilute things. We don't want to do that. Our typical systolic blood pressure target here at this point is going to be 80 to 90. So generally we're going to administer a fluid bolus of an isotonic crystalloid, normal saline or lactated ringers usually, and then reevaluate. What we're aiming for is a mean arterial pressure of 60 because that is enough to perfuse to the cerebrum. Now another thing that's coming around, it's not made its way down to advanced, but is at the paramedic level in some areas, is TXA. And what this TXA does is it helps prevent your blood clots from breaking down once they've formed.